Good morning. This is the second part of semester one test revision, and we will be resuming our discussion about ECG and how to use ECG, the ECG for diagnosis, and we will start by the normal sinus rhythm. When we say normal sinus rhythm, what questions can be asked here? First of all, what is a normal sinus rhythm? It is a heart rhythm that arises from the sinoatrial node. So the first question is, what does this term refer to or define, or what's meant by the normal sinus rhythm? Okay, so a normal sinus rhythm is a rhythm that originates in the sinoatrial node. This is an answer to what is a normal sinus rhythm. It is a rhythm that originates in the sinoatrial node. And if it is, the question is not just what's the normal sinus rhythm, and if the weight of the question in the test is higher, or if I ever ask you about mentioning the characteristics of a normal sinus rhythm, so you have to say all the characteristics in detail. So I might ask you question number 2 might be about the characteristics of a normal sinus rhythm, the characteristics that help you diagnose this ECG strip as a normal sinus rhythm. Or the question might be like this. It might be, what type of rhythm is this? And justify your answer. So if you say that this rhythm is a normal sinus rhythm, and I ask you to justify, then you have to say the characteristics. So what are you going to do in order to justify or to prove that this is a normal sinus rhythm? First of all, you're going to check the regularity of the rhythm, because number one, the regularity, because if the rhythm is irregular, then it is not a normal sinus rhythm. It cannot have originated from a normal sinoatrial node. And then after having made sure that the rhythm is regular, you have to calculate the rate. Of course, in order to check that the rhythm is regular, just look at the R peaks, okay? If the distance between all the R peaks is equal, then this is a regular rhythm. And then you're going to calculate the rate. And if the case is like here on the slide, that the almost all our waves start at the beginning of a large box and end at the end of a large box, then you can just count the number of large boxes and divide 300 by the number of large boxes. But most of the time, this is not the case. And that's why you had better divide 1,500 by the number of small boxes in between the R peaks. If you find that the rate is between 60 and 90 and the rhythm is regular, then it is most probably a normal sinus rhythm. But this is not enough. You have to continue your justification and your evidence that this is a normal sinus rhythm. So number 3, you have to highlight that every QRS complex is preceded by an R wave. So this would be the third point you would be talking about. There is one P wave preceding each QRS complex, and then you're going to make sure that the PR interval is within normal, meaning that the PR interval is between 0.12 and 0.20 seconds, which means 3 to 5 small squares, because every small square is 0.04 second. Of course, when the rhythm is regular and the rate is 60 to 90 within this normal interval of 60 to 90 beats per minute, and there is a P wave preceding every QRS complex, most probably the PR interval will be within the normal limits. And then you're going to make sure that all the QRS complexes are similar to each other and that they are narrow R waves, meaning that the width of the R wave should never, the width of the QRS complex should never exceed 3 small squares, which is 0.12 seconds. And the R waves, as I said, should be narrow. And finally, the QT interval. Because if the QT interval is long, say, for example, you found out that the QT interval is longer than the maximum duration of the QT interval, which is 0.44 seconds, which is about 11 small squares, then you would say that this is a normal sinus rhythm, but the patient suffers from a prolonged QT interval, okay? Moreover, you should know the normal duration of the segments and intervals, where they start and where they end, because you might have, for example, complete questions about fill in the blanks questions about this, or you might be asked straightforward in a straightforward manner about how to define the PR segment, where to start, where to end, and the duration. So the PR segment is from the end of the P wave to the beginning of the Q wave. This is the first question. What does the PR segment refer to? So you would say that it is the segment between the end of the P wave and the beginning of the Q wave. But you might also be asked about the significance of the segment. The segment represents the duration of time or the delay between the atrial depolarization, the end of atrial depolarization, and the beginning of ventricular depolarization, which simply means AV conduction. I might ask you another question that is related to the PR segment. For example, I might ask you about the significance of the PR segment in general. So you would say the delay between the end of atrial depolarization and beginning of ventricular depolarization, which is the AV conduction time. But I might ask you about the significance of a prolonged PR interval. If the PR interval is prolonged, this simply means that we have a prolonged AV conduction time. As we said before, what's the difference between an interval and a segment? An interval is a segment plus a wave, and therefore the PR interval is the time duration between the beginning of the P wave and the end of the PR segment. So it includes the P wave, it includes all the P wave as well as the PR segment, and therefore it represents the time duration, not like the PR segment from the end of atrial depolarization, but it represents the time needed for atrial depolarization to occur, and then for that atrial depolarization to be conducted to the ventricles. For the ST segment, of course, you know that the ST segment, if this is the QRS complex, QRS complex, then the ST segment starts at the end of the S wave and ends at the beginning of the T wave. And the ST segment is just a segment. So it represents the time duration between the end of the QRS complex, which is ventricular depolarization, and the beginning of the T wave, which is ventricular repolarization. The QT interval starts at the beginning of the Q wave here and ends at the end of the T wave, and therefore it includes all this. It includes the time duration needed for ventricular depolarization followed by ventricular repolarization. I wouldn't accept such an answer like, for example, it represents the time for the QRS complex and the T wave. No, I need to know what the QRS complex represents and what the T wave represents. The QRS complex represents spread of depolarization over the ventricles, and the T wave represents spread of depolarization over, the T wave represents repolarization of the ventricles. You might also be asked about the QRS complex in detail. So what does the Q wave represent? It represents the depolarization of the septum, the interventricular septum. Is it enough to say this? No, you have to say in which direction, from left to right. And then what does the R wave represent? The R wave represents depolarization over the bulk of the ventricles. So it represents the change of the direction of depolarization, and it represents spread of depolarization over the main bulk of the ventricular muscles. And then the S wave, and as we said before, the S wave represents the final depolarization of the ventricle. So you first depolarize the septum, and then you depolarize the ventricles, and then a final small wave of depolarization is the S wave. You should also know the properties of a normal P wave, because when you say, for example, that this is not a normal sinus rhythm, because like in atrial flutter, for example, or in atrial fibrillation, when it is not a normal sinus rhythm, then you cannot have a normal P wave. So if you say, or I might get you a tracing, an ECG tracing, where you have abnormal P waves, abnormal in shape, in duration, and I might ask you, are these normal P waves or abnormal P waves? And justify your answer. So you are going to see the width of the P wave. Is it more than 3 small squares? It should not be more than 3 small squares. So this is the first small square, second small square, and third small square. By the way, because there are still students who are confused with the large squares and the small squares. The large squares are always demarcated by heavier ink. So you would have a heavy red line or blue line like this, or black line in the photocopied sheets. And then you will have a lighter. Let me draw them in a dotted way like this, because I don't have a thinner pen. Okay, so the large squares are demarcated by solid, heavier lines, and the small squares are demarcated by lighter, thinner lines. Okay, they're not dotted, of course. So first of all, you're going to count the small squares. They shouldn't be more than 3 small squares. And then you're going to see the height of the P wave. The height of the P wave should not be more than 2.5 millimeters, which just means 2.5 small squares. These are 3 small squares. It should be less than 2.5 small squares, okay? So if you find, for example, that the amplitude of the P wave, the height of the P wave is 4 millimeters or 5 millimeters, and the P wave looks like this, for example, you would say taller than normal P waves. And usually when they are taller than normal, they are a bit peaked. And this occurs whenever you have pulmonary hypertension, whenever you have elevation of the pressure in the pulmonary artery following chronic hyperflow through the pulmonary artery. Just say pulmonary hypertension. Of course, this is a higher level of difficulty, and most probably you will not be asked about the cause of tall peaked waves, but you have to know that this is not a normal P wave. Sometimes the P wave is notched like this, and this is, of course, you just, similarly, you just have to know that this is not a normal P wave, because a normal P wave should be rounded, should be smooth, should not be peaked, should not have a height more than 2.5 and a width more than 3 millimeters. Now, sinus tachycardia, as I said in the previous video, when you say the definition of sinus tachycardia, it's not enough to say it's an abnormal it's an abnormal rhythm where the rate is above 90 beats per minute or even above 100 beats per minute. First of all, you have to say that tachycardia means a rapid heart rate, meaning that it is a heart rate that is higher than the normal, and therefore that heart rate is more than 90 beats per minute, not 100 actually. I prefer the references which say that tachycardia is a rapid heart rate that is higher than 90 beats per minute. What am I answering now? I am answering the question, what are the characteristics of sinus tachycardia? So it is a rapid heart rate, more than 90 beats per minute, but more importantly, and this is what maybe we haven't emphasized during class time, but which is important, that this occurs at rest. Because if you have a heart rate that is more than 90 beats per minute because you're walking fast, or because you're running, or because you're working out, you're exercising for a reason or another, then this is normal that there would be a physiological increase in your heart rate. This is a physiological response. And you also have to say that it is a regular heart rate. Okay, so it is fast, it occurs at rest, it is regular, it's not irregular. And more importantly, and maybe this is not written on the slide, that it is sinus, meaning that it originates in the sinoatrial node, and therefore it should have all the other characteristics of the sinoatrial node. Because it's not because the rate is rapid that we are going to miss the other characteristics of the sinoatrial node. No, the only abnormality is that the rate is high, is faster than normal at rest, but it is regular. It originates in the sinoatrial node, and therefore, since it originates in the sinoatrial node, it will have all the other characteristics. It will have a P wave before each QRS complex. The P wave is normal in amplitude, normal in shape, meaning that it is rounded, it is smooth, and the PR interval is normal. And it's not enough to say that it's normal. You should say between 0.12 and 0.2 seconds. The ST segment is normal. The QT interval is normal between 0.36 and 0.44. All the QRS complexes are similar to each other, and all the QRS complexes have a duration less than 0.12. So what does this mean to recap? To recapitulate all this, this means that if I ever ask you to justify why this is sinus tachycardia, first of all, of course, you have to identify the rate or calculate the rate. And you would say all the characteristics of normal sinus rhythm, and the only abnormality would be a rapid heart rate that occurs at rest. Similarly, for sinus bradycardia. Sinus bradycardia is a slow heart rate, less than 60 beats per minute. But other than this, all the other characteristics would be like sinus tachycardia. So again, if I ask you to justify, to diagnose first what the ECG strip is, you would say, of course, sinus bradycardia. How did you know? You see, it's regular. You see, you calculate or you count the number of big or small boxes between two successive are peaks, and you find out that it is less than 60, so you find the rate 50 beats per minute, but it is regular. And then you check and find that every QRS is preceded by a P wave. The P wave is normal. The QRS complexes have a duration of less than 0.12 seconds. The PR interval is isoelectric and between 0.12 and 0.20. The QT interval is less than 0.44. So if you want to give evidence or to make sure that, or to identify or to prove that this is sinus bradycardia, so you have to prove that it has all the characteristics of a sinus rhythm, except that the rate is slow. Why is this important? Because sometimes you might be confused between sinus bradycardia and an AV nodal rhythm. For example, the AV nodal rhythm might be 50, for example, because the intrinsic rate of the AV node is between 40 and 60. So if you find that the rate is 50 beats per minute, so don't rush to the conclusion that this ECG strip is a sinus bradycardia. So you have to ask yourself, is this sinus bradycardia or is this AV nodal rhythm? You have a regular rhythm whose rate is 50 beats per minute. So it might fit into sinus bradycardia or fit into an AV nodal rhythm. So you have to check the rest of the characteristics. If you find out that all the criteria fit with sinus bradycardia, then it is sinus bradycardia. So what would be the major differences here when we list or enumerate the characteristics? Where would we find the difference between sinus bradycardia and an AV nodal rhythm? We would find it in two important criteria. The first one is the P wave, and the second one is the PR interval. If you find that the PR interval is shorter than 0.12 seconds, and if you find that the P wave is inverted or completely absent, then it's not a sinus bradycardia, it is an AV nodal rhythm. Why would the P wave be absent? The P wave would be absent just because the PR interval has become so short that the QRS complex is superimposed on the P wave, meaning that if this is the inverted P wave of the AV nodal rhythm, and this is the QRS complex, this is the PR segment. If the PR segment starts getting shorter and shorter, so you would find that the two waves, the QRS complex and the inverted P wave, would be superimposed on each other. So why is it at the expense of the P wave? Because the P wave is the smaller deflection, so it wouldn't appear, but it might distort a bit the QRS complex. Of course, this is a higher level of difficulty that you're not supposed to know, or all what you have to know is that the main differences between sinus bradycardia and AV nodal rhythm is that an AV nodal rhythm has an inverted P wave and a very short PR segment. Atrial fibrillation is not arising in the SA node. So up till now, we have seen three rhythms. So I might ask you about the heart rhythms that originate in the sinoatrial node. So you would say the three: normal sinus rhythm, sinus tachycardia, and sinus bradycardia. But I might ask you about atrial rhythms that arise in ectopic atrial foci. Foci is the plural of focus. So in such a case, you would talk about atrial fibrillation and atrial flutter. Atrial fibrillation and atrial flutter. Let's start by atrial flutter because it is a regular rhythm. Atrial flutter arises from an ectopic atrial focus, and therefore you're not supposed to find a normal P wave. You would find abnormal P wave. And these abnormal P waves have a sawtooth pattern like this, and they are called flutter waves. And they are more than one before every QRS complex. And it depends upon how much delay and block the AV node does, because in atrial flutter, you have a rapid ectopic focus, a rapid ectopic atrial focus, a rapid ectopic atrial focus. And when I say ectopic, I mean abnormal. And that rapid ectopic atrial focus is outside the AV node, outside the SA node. And it is rapid. It beats at 300, for example, beats per minute in the atria. And all the atrial muscles have to obey it. Why? Because it is an ectopic focus that is capable. It has all the characteristics of the sinoatrial node. It has an unstable membrane potential. It can generate impulses on its own, but moreover, it is faster than the SA node, and therefore it would take over, and all the rest of the atrial muscles have to obey it. So all the atrial muscles will be depolarized at that high rate. But the AV node will not allow this to be transferred to the ventricles. So in the ventricles, you might find that the rate is only 150 beats per minute, which means that we have divided the rate by 2. So what would you find? You would find 2 P waves for every QRS complex. But if the AV node decides to do this is what we call a 2-to-1 block, meaning that you divide the atrial rate by 2 in order to protect the ventricles. But the AV node might decide to do a 3-to-1 block, and in which case the ventricular rate would be only 300 divided by 3, 100 beats per minute. So you would find 3 depolarizations of the atria followed by 1 depolarization of the QRS complex, meaning that this you would find 3 P waves for 1 QRS complex and a 3-to-1 block. So if I ever ask you, what is a 2-to-1 block? This means that for every 2 depolarizations of the atria, we would have 1 depolarization of the ventricles. And this also means that the AV node transfers only half the impulses to the ventricles. And this only, why does this happen? In order to protect the ventricles against a high rate type. Why is a high rate injurious to or harmful to the ventricles? Because if you have a high heart rate, this would shorten the cardiac cycle, and the shortening of the cardiac cycle occurs at the expense of diastole, and therefore there would be 2 bad consequences. The first bad consequence is that the ventricles do not fill enough and do not pump enough blood to the body, and therefore there would be a drop in perfusion of the tissues with blood. And the second consequence would be that the coronary arteries would not have enough time to fill, and the body would be exposed to ischemia. Okay. In atrial fibrillation, on the other hand, we still have an ectopic atrial focus. We still have a high atrial rate, and therefore the AV node decides to diminish the rate by delaying the conduction, and we find that the ventricular rate is lower. So if I ever ask you about the reason behind the difference in rate between the you should bear this in mind. You should be very careful, and you should always remember this, that whenever you have an ectopic atrial focus, you will have an AV block. And whenever you have an AV block, then you will have a difference between the atrial rate and the ventricular rate. When does this happen? It happens in 2 conditions only: atrial flutter and atrial fibrillation. The only difference is that in atrial flutter, you have a very definite pattern, regular pattern, 2-to-1 block or 3-to-1 block. In atrial fibrillation, there is atrioventricular block. There is protection of the ventricles. The atria are beating at a rate that is different from the ventricles. The atria are beating at a much higher rate than the ventricles, but the only difference is that the rate is irregular. So in atrial fibrillation, we have an irregular rhythm, and we cannot identify any P waves. We have chaotic P waves. We have a chaotic isoelectric lines. You cannot say that, you cannot even count the number of P waves before each QRS complex. There is no regular pattern. And as you see, atrial fibrillation is an irregular rhythm. Moreover, there is an important question related to atrial fibrillation, which is why are the QRS complexes of normal duration? We say that when the QRS complexes are normal, they have a duration of less than 120, and therefore the QRS complexes are normal because they are normally conducted through the AV node. In ventricular flutter and ventricular fibrillation, we have ectopic foci, but these ectopic foci are originating in the ventricles. Ventricular flutter is very characteristic because ventricular flutter has a sinusoidal wave appearance. So if I ever ask you about the evidence that this is ventricular flutter, you would only mention 2 or 3 reasons. First of all, the absence of the P waves. Maybe it's not written here, and this is a real defect in the content of the slide. There are no P waves. Why? Don't the atria depolarize? Doesn't the SA node work? It is working, and the atria are depolarizing. And there are P waves, by the way, but they are not visible on the ECG. So we had better say no visible P waves. Why aren't they visible? Because they are hidden by the very rapid sinusoidal QRS waves. We cannot call them QRS complexes. We just call them sinusoidal ventricular waves, and they hide the P waves. But this doesn't mean, by the way, if the ventricles have their own foci, but by the way, ventricular flutter results from an ectopic ventricular focus. And it is that ectopic ventricular focus that is driving the ventricles. But this doesn't mean that the atria don't have their focus, and maybe it's a normal focus. Maybe it is the sinoatrial node, but you cannot visualize the P waves. The second thing is that the ventricular rate is regular, and the third one is that the rate is between 250 and 300. So again, what are the characteristics of ventricular flutter? It's an abnormal rhythm that results from an ectopic ventricular focus. This is number 1. Number 2, there are no visible P waves. Number 3, the rhythm is regular. And number 4, the rhythm is between 250 and 300 beats per minute. In ventricular fibrillation, again, it is an ectopic ventricular focus, and we have bizarre shaped. So the first characteristic, it is that we have an ectopic ventricular focus that arises in the ventricles. There are no visible P waves. They are there, but they are overridden by the QRS complexes. The rate is high, again, like in ventricular flutter, but it is not regular, it is irregular, and therefore ventricular fibrillation is an irregular rhythm. So the characteristics are an ectopic focus, no visible P waves. It is an irregular rhythm. The QRS complexes are bizarre shaped, and number 5, the rate is fast. We have discussed the AV nodal rhythm before, and therefore I'll not be repeating it. And then, of course, you have the valvular diseases. The main defect in mitral stenosis is that the cross-sectional area of the valve is narrow, and therefore the blood is passing through a narrow valve during diastole. So we would have a turbulent blood flow, and that turbulent blood flow occurs during diastole when the valve is open. So we would have a diastolic murmur, meaning that this diastolic murmur lies after S2 or between S2 and the remaining S1 and the next S1. In the longer diastole period, it is a mid-diastolic murmur with a pre-systolic accentuation, meaning that it increases just before a systole. The fourth characteristic of the murmur is that it is best heard at the apex, and it is not enough to say at the apex, but you should say in the fifth intercostal space, mid-clavicular line. Mitral regurgitation, on the other hand, would occur during systole. So it is a systolic murmur, and it occurs during the whole systole. So it is a hollow systolic murmur, meaning that it lies between S1 and S2, and it occupies the whole duration of systole. And again, it is best heard at the apex, which we also call the mitral area. So you might call it apex, or you might call it the mitral area. Tricuspid stenosis is similar in all characteristics to mitral stenosis, except that it is heard over the tricuspid area, which is the fifth intercostal space, left sternal edge. Okay, this is as regards tricuspid stenosis. As regards tricuspid incompetence, it is very similar to mitral incompetence, meaning that it is a hollow systolic murmur, and the only difference is that it is heard again in the tricuspid area, which is the fifth intercostal area space, left sternal edge. Aortic stenosis results in we have, by the way, I forgot to tell you about the or to remind you of the cause of murmurs in case of incompetence. In case of incompetence, the cause of the murmur is the backflow. And when you have backflow of blood, again, you have turbulence. And if you have turbulence, then you will have a murmur, okay? In aortic stenosis, again, the cause is stenosis. The cause of the murmur is that we have a narrow valve, and if we have a narrow valve, then we have a turbulent blood flow, but unlike mitral and tricuspid stenosis, it is a systolic murmur. And it's not, by the way, a hollow systolic murmur. This is another difference, is that it is a crescendo, it is a mid-systolic murmur that is diamond shaped, meaning that it is a crescendo and then decrescendo murmur. It increases in intensity and then decreases in intensity. The second difference between aortic stenosis and mitral stenosis is the site or location where you best hear it, which is the aortic area. And the aortic area is the second intercostal space, left sternal edge, or the left second intercostal space. Similarly, pulmonary stenosis. Pulmonary stenosis, again, is due to a narrow valve. It is due to a turbulent blood flow, but it is a crescendo-decrescendo murmur, and the only difference is that it is heard over the pulmonary area, which is the second intercostal space to the left second intercostal space. In aortic incompetence, of course, incompetence results in Aortic incompetence results in backflow of blood, but this time the backflow of blood occurs during a ventricular diastole, and it is very characteristic because this murmur is an early diastolic murmur, meaning that it is decrescendo. It starts high and then lowers down. So aortic incompetence is very characteristic because it is an early diastolic murmur. It is due to backflow, and backflow occurs during diastole, and backflow results in turbulence, and it is a decrescendo murmur or an early diastolic murmur. Similarly, pulmonary incompetence. The only difference is in the location. Of course, you should know the characteristics of the arteries, and the most important characteristics of the arteries are a thick tunica, a thick tunica media, because they have a thick layer of smooth muscle fibers. And these smooth muscle fibers, as we said several times, contract and relax in order to constrict or dilate. And in the arterioles, this is very important. In the arterioles in particular, this is very important to control blood flow to the tissues. So the main vessels that control blood flow to the tissues are the arterioles, and to control the total peripheral resistance, which controls the blood pressure. They also have elastic fibers, and they infer elasticity to the arteries and arterioles. And elasticity is important both during systole to accommodate blood and during diastole for recoil. So if the artery is not elastic, if the artery is inelastic, like during atherosclerosis, for example, if the artery is not elastic, then it would not accommodate the blood and result in hypertension or increase in systolic pressure, especially systolic hypertension, and it would not recoil during diastole, and there will be a diminution of the diastolic blood pressure. Okay, so this is the importance of the elasticity of the arteries. And then blood pressure, the definition of, if you are to define systemic blood pressure, then it is the pressure of the blood on the inner wall of the large arteries that are close to the heart, like the aorta. Of course, we have a systolic, we define systemic blood pressure by two numbers, the systolic blood pressure and the diastolic blood pressure. Normally, it is in the range from 120 to 150 for the systolic and 80 to 90 for the diastolic. And a systolic pressure is the maximum pressure that is obtained during systole, and the diastolic pressure is the minimum pressure obtained during diastole. So you should be very precise and focusing and understand the question well. Am I asking about systemic, the definition of systemic blood pressure in general, or am I asking about systolic blood pressure? Am I asking about diastolic blood pressure, or about systolic hypertension and diastolic hypertension? So here we have several definitions. The first definition is systemic blood pressure. The second definition is systolic pressure. The third definition is diastolic pressure. The fourth definition is pulse pressure, which is the difference between systolic and diastolic pressure. These are easy definitions: systemic blood pressure, systolic, diastolic, and pulse pressure. And then you have number 5, systolic hypertension. Systolic hypertension means that it is only the systolic pressure that is higher than normal. Number 6, diastolic hypertension means that it is only the diastolic blood pressure that is higher than normal. And finally, systemic hypertension, which means that both the systolic and diastolic blood pressures are elevated, the systolic pressure being more than 150, the diastolic blood pressure being more than 90 millimeters mercury, but on 3 separate occasions. And then you might be asked about the measurement of the blood pressure, especially these sounds, and I might give you a certain value as we did in the worksheet for the normal blood pressure, 120/80, for example, and I might ask you, what would happen if the pressure in the cuff, here in the cuff, when I say the pressure in the cuff, I mean the external pressure. So what happens if the pressure in the cuff is more than 120, which is the highest systolic pressure of the patient? You would say this. You would say, I would hear no sound. Why wouldn't you hear any sound? So this is what is written here is what happens. What is written to the right is what happens. What is written to the left is why, the justification. So if it is above 120, what am I talking about? I am talking about the pressure in the cuff. If it is over 120, then I hear no sound. Why? Because the artery is closed. Type. If it is lower than 180, but though I hear no sound. Why? Because the artery is fully open. Type. And so what? When it is fully open, I have smooth laminar flow. And then what happens in between? We hear irregular sounds. We hear, intermittent sounds, which are called Korotkoff sounds. Why? Because when you hear the sound, the artery is partially closed. This is very important. You have to know it. Of course, this is an important topic that you should understand well. The precautions, of course, for blood pressure measurement are to put the device at the same level of the heart to measure, for better representation and more accurate measurement, to measure on the left side, in the left brachial artery, because it is closer to the heart. We select the brachial artery because it is the closest accessible artery to the heart. The cuff shouldn't be too loose nor too tight. And when you inflate the cuff, you should inflate it firmly and rapidly. And then while deflating the cuff, it should be slowly. And then finally, you should consider the auscultatory gap. In some individuals, especially in hypertensive individuals, there is a gap between the highest pressure, the actual pressure of the patient. Say, for example, it is 120 millimeter mercury, and the lower pressure that comes next to it, which is, for example, 160. So you might hear the last Korotkoff sound at 160 and be contented with this and say the systolic pressure is 160. But if you raise it 20 millimeters more, you will find that actually you can hear another Korotkoff sound, and that the pressure of the patient is 120 or even 180 or even 190. This gap where you hear no auscultatory sounds, although the pressure is high, is called the auscultatory gap. We have mentioned hypertension and the definition of hypertension. Of course, you have to know that hypertension injures the inner blood vessels because there is stress on the inner blood vessels, and it results in roughness of the inner blood vessels. And if the inner wall of the blood vessels is rough, then platelets would be destroyed. And if platelets are destroyed, then there would be agglutination and clotting. A blood clot would occur, and the blood clot might result in a brain stroke, for example, or it might result in myocardial infarction. But there is another, this is a complication. So if I ever ask you about complications, you would talk about roughness. I mean, complications of hypertension. You would talk about roughness and destruction of the platelets and blood clotting and obliteration of the blood vessels that might result in a brain stroke or myocardial infarction. but the hypertension itself might result in another serious complication, that is hemorrhage, and it is serious, especially if it occurs inside the brain. Complications of hypertension differ from the clinical picture, from the symptoms and signs of hypertension. Symptoms and signs of hypertension are headache, tinnitus, dizziness, and sometimes nausea and vomiting if hypertension is very severe. These are the symptoms, but sometimes, as you know, hypertension might have no symptoms, and the patient might have a hypertensive crisis without symptoms, and that's why we call hypertension the silent killer, because the patient may have an attack of cerebral hemorrhage and death without having any previous symptoms. Of course, the structure function adaptation of the capillaries have been mentioned before in the first video that we mentioned in the classroom. And the first video, the first Zoom session that we did, and that was uploaded before part 1 of that video. Of course, you should know the difference between arteries and veins. Veins have a thinner tunica media, and therefore they contract less, and their lumen is not patent, their lumen is collapsed. Veins have less elastic fibers, and therefore less elasticity and less recoil than the arteries, and that's why veins have an internal system of valves along their course. Arteries do not have an internal system of valves along their course. Only large arteries like the aorta and the pulmonary artery have such valves. The flow of blood against gravity in the vein is helped by 2 factors: the presence of muscles around, the tone of the muscles and the contraction of the muscles, and the valves. The valves allow one-way flow of blood towards the heart and prevent backflow. If one of these 2 mechanisms that ensure return of the venous blood to the heart is weak, then the patient would suffer from varicose veins. And varicose veins are enlarged tortuous veins due to pooling of blood inside the veins, especially in the veins of the lower limb, and because they have the main burden of carrying blood upward against gravity, and especially in people who stand up for a long period of time. They do not contract their muscles efficiently. They have weak muscles because they are old, debilitated, weak people, or because they have congenitally weak valves. Sometimes we give, of course, medication to strengthen the wall of the veins, and we advise the patient to avoid standing up. These are the pieces of advice that you can give to the patient to keep contracting their muscles of the lower limbs, to avoid standing up for a long period of time, to sleep, to lie down and raise their legs. And you can give them medications to strengthen, like vitamin C and rutin or vitamin P. But sometimes all this fails, and the only solution is sclerotherapy, meaning that you inject the vein with an irritating chemical that causes inflammation in the wall of the veins and obliteration of the vein, to avoid all the pain that the patient is in, because varicose veins are not only cosmetically bad, but they're also very painful. When all this blood pools down in the vein and the vein wall or the wall of the vein is distended to such a large extent, then the patient suffers from chronic pain in the lower limbs. So chronic pain in the lower limbs is an indication that you have to examine the lower limbs carefully and see whether the patient has varicose veins or not. Of course, you know the systemic circulation, the pulmonary circulation. Of course, you should know that the lungs have a double blood supply, that the liver has a double blood supply, the hepatic artery and the portal vein. You should also know the difference between the pulmonary and bronchial arteries, because the pulmonary arteries carry deoxygenated blood, whereas the bronchial arteries carry oxygenated blood. Exchange is, of course, very easy. Of course, left ventricular failure and right ventricular failure and their clinical picture is very important. If the patient has left ventricular failure, then there will be symptoms due to low cardiac output, like low blood pressure, fatigue, dizziness, and there would be failure of pumping all the blood, and therefore some blood will stay in the left atrium, and therefore there would be back pressure on the lungs that would cause orthopnea, meaning that when the patient lies down, he has dyspnea. It might also cause paroxysmal nocturnal dyspnea, meaning that every now and then during night, when the patient is sleeping, he stands up, he sits down in order to have some relief of his dyspnea or simply dyspnea. Dyspnea is the lightest one. You just have, for example, exertional dyspnea, but more severe is that when you lie down for an hour or two and then you feel that you have difficult breathing, the most serious one is orthopnea, because just after you put your head on the pillow, you feel that you cannot breathe and you have to sit down. All this is due to what? Is due to blood accumulating in the left atrium, back pressure on the lungs, and pulmonary congestion. In right ventricular failure, on the other hand, the right ventricle cannot pump blood in the pulmonary artery, and there are congested neck veins. And you have to know, this is very important, how to examine congested neck veins. The patient is seated at 45 degrees. You put a ruler or a sheet of paper horizontally at the sternal angle, and then you measure the height. You see visible pulsations here. The internal jugular vein is not, you cannot feel venous pulsations, but you can see them, and you will find that you will measure the vertical distance between the sternal angle and the upper border of the pulsation. This vertical distance should not be more than 4 centimeters. If more than 4 centimeters, then the patient has congested neck veins. And if the patient has congested neck veins, then this is an indication of right ventricular failure. And if the patient has right ventricular failure, then definitely he will have lower limb edema. So it's a triad that starts by right ventricular failure, resulting in congested neck veins and lower limb edema. The coronary circulation, of course, you have to know why the coronary arteries are easily obliterated. And we said that in the first part of the video. You should know the difference between angina pectoris and myocardial infarction. Clinically, you give the patient a sublingual coronary dilator. If there is immediate relief, then it was angina pectoris. If there is no relief, then there is myocardial infarction. How can you further confirm myocardial infarction? By cardiac enzymes. If elevated, then it is myocardial infarction. If not, then it is not. And further indication during the pain by ECG. If the ST segment is depressed, then it is angina. If it is elevated, then it is myocardial infarction. You have to inject a medication that dissolves the clot within 6 hours if it is diagnosed as myocardial infarction. Before the ECG, before the sublingual coronary dilators, and before the cardiac enzymes, what makes a difference between the angina pectoris and myocardial infarction is the clinical picture. But the clinical picture is not decisive. Of course, the symptoms, the crushing pain, the squeezing pain is more intense in case of myocardial infarction. It is not relieved by any means, not relieved by rest, not relieved by coronary dilators. but it's not decisive. What is decisive are the cardiac enzymes, the ST segment in the ECG, and the sublingual coronary dilators. This is as regard, of course, you have to know what a pathological Q wave is, and it is seen only several months after a cure from myocardial infarction. We discussed atherosclerosis and the building up of fatty material and how it can cause a diminution of blood flow to the organs because of a narrower vessel, and meanwhile it results in blood clotting and bleeding. Okay, and of course you have to know the differences. You have to know the lymphatic organs very well, and you have to know the differences between the lymphatic vessels and the veins. The lymphatic vessels, the small ones, are similar to the veins, meaning that they have valves along their courses, and you have to know the differences. The lymphatic vessels do not contain blood cells, whereas the veins contain blood cells. The lymphatic vessels start openly. They do not start by capillaries, whereas the veins start by capillaries. But similarly, the lymphatics and the veins are squeezed by the muscles, and this helps lymphatic return and venous return. Valves are common between the lymphatics and the veins. And of course, you should know one important difference, that there are lymph nodes along the lymphatics, and that the lymphatics contain lymph, which has a high content of lymphocytes. So the main difference between them is open and closed, an open system and a closed system. Why do lymph nodes get enlarged when inflamed? Because they contain lymphocytes, and when the lymphocytes are exposed to a foreign antigen, they are stimulated to divide at a rapid rate, so the size of the lymph node increases, the blood flow increases, and there is an immune reaction that results in inflammation and increased size of the lymph node to kill the intruding pathogen. I'm sorry, I was going fast because the information is huge, actually, and I hope that inshallah tomorrow you would do well on the test, and that most of you would answer all the questions amazingly, inshallah, as usual. And see you tomorrow, inshallah, and good luck. Bye-bye.